ह्यानंतरचे जे आपले स्पीकर आहेत डॉक्टर भूषण मिसाळ सर, ऑनररी कन्सल्टंट न्यूरोलॉजी, आदित्य बिर्ला मेमोरियल हॉस्पिटल, पुणे, since November 2021, currently running a movement disorder clinic in a teaching hospital in Pune, India, actively involved in proprietor evolution of patient for deep brain stimulation for various indication, regularly inject botanical toxin for patient of dystonia and spasticity, work as internal medicine resident at IJMC Nagpur, India, completed 1-year fellowship in movement disorder at Jacklock Hospital, Mumbai in July, work as assistant professor in Department of Neurology at Bharatiya Vidyapeeth Medical College and Hospital, Pune. Sir, I invited you at the stage for your lecture.
Thank you, NIMA and Aditya Birla Memorial Hospital for providing me this opportunity. I'm going to talk about clinical features and management of Parkinson's disease. I'll go a bit fast because time is limited. I just have a small disclaimer. Please don't videotape this session because there are some videos of patients. So what is Parkinson's disease? James Parkinson's described this disease in 6 patients in 1817. That is the reason why this eponymous name was given to this disease, because he used to watch from his balcony people going around on the street, and then he described 6 cases and he put it in an essay in a medical journal, and that's how the name came to be known by his name. What is the basic pathophysiology? There is an area called substantia nigra in the midbrain, and in that area there are dopaminergic neurons which secrete dopamine, and this chemical is required for movement, and when these cells start dying or they get diminished, that time we get features of Parkinson's disease. So these are the dopaminergic neurons in that area, and through various... You can't hear me? Huh. So this is a dopaminergic neuron, and through various steps dopamine is created in these neurons, and then it is secreted, and from here it goes a signal is transmitted further, and this results in movement. So through various steps dopamine gets secreted, gets produced, gets secreted, then it acts on these receptors, and whatever excess is there, it gets degraded through here, through these 2 enzymes, catechol methyl transferase and monoamine oxidase. So all our medicines that we give, all are centered around this whole pathway through which dopamine acts. So the most essential medicine that we have is levodopa. Levodopa it's a prodrug which gets converted into dopamine. Dopamine gets secreted. There are certain dopamine receptors. So if dopamine is less here, if these neurons start dying, then we can give bromocriptine, ropinirole, pramipexole, which will act on these receptors. Or if we somehow try to reduce this degradation which is happening here through these 2 enzymes, if these 2 enzymes are inhibited with rasagiline, selegiline or tolcapone, then again dopamine will increase here, and then the symptoms will reduce. So these are the clinical features, cardinal features, these 4 features: bradykinesia, rigidity and tremors. This is the cardinal triad, and plus postural instability. So this is how the patient will look. Now you will think whatever is written here, this is showing something else. These are other features. These are non-motor features. These are motor features, means movement-related features. Means patient will be slow, he will be rigid, there will be tremors, and he will be very unstable, or there will be imbalance. Plus, there will be other non-motor features. So this is the Parkinson's iceberg. This is what we see: tremor, rigidity, akinesia or bradykinesia, and postural disturbances. But what we don't see is there is lot more that is going on in the body that we cannot see: constipation, speech or swallowing difficulties. then anxiety, loss of smell, lack of facial expression, hypotension, and many more. Depression, anxiety, pain, gastric reflux, hallucinations, dementia as well. They can have erectile dysfunction as well. So we need to address not just this, but all these things as well. So what is bradykinesia? Brady means slow, kinesia means movement. So slowness of movements, slowness of finger tapping or eye blinking, alternate movements, slowness of walking, that is gait, taking short steps, reduced arm swing, and slowness and difficulty in turning. So all these features can be seen. Rigidity in simple terms means stiffness of limbs, which is an extra pyramidal problem. Stiffness because of other reasons like pyramidal problem is called spasticity. So here it is called rigidity in Parkinson's. In stroke we get spasticity. Then we have tremors. Usually these tremors are unilateral. They are at rest, means when patient is taking rest, not doing any activity, then he'll get, when he's watching TV, he'll start getting tremors. And usually they are pill rolling like this. So this is one of the patients. Look at his face. Hardly there is any blinking. There is no facial expression. And the classical pill rolling tremors present at rest. They are also present at posture. And usually they are more on one side. If they are there on both sides, then usually it is not Parkinson's. It could be something else like essential tremor. There is slowness. Look how much time it is he is taking to just get up from the chair. Now he has a stooped posture. See, the tremor is on one side only, not on the other side. He is not moving his arms at all, and his steps are also very short. This is another patient. Again, she has a masked face, hardly any expressions on her face. When we ask them to do tapping movements, the movements are very slow. There is continuous tremor. Usually it is more on one side. So again, there are bilateral tremors, but she has difficulty doing these movements more on the left side than the right side. Right side relatively better. Left side is much worse. Hardly she is able to do anything. Again, difficulty in getting up from the chair. Very slow. She is stooped. Posture is very stooped. Can't stand straight. And look how she is walking. Baby steps, very small steps. Hardly moving her arms when she is walking. We move like this when we walk. Hardly she is moving her arms. Turning is very difficult for her. So these are the features when we should suspect Parkinson's disease. Then there is postural instability, meaning there is imbalance while walking, tendency to fall asleep, especially backwards or forwards, short steps, for shuffling steps, and tendency to catch center of gravity. Now look at him. He is very rigid. So he is falling like a log of wood. Normally when we fall, we'll bend from the waist, our hands will go forward. But when they fall just like that, like a log of wood. No reflexes. Another, again, hand is not going back, he's not bending, leg is not going forward, he's just falling down like a log of wood. Okay, so now these are the main cardinal features. Now the medical management in brief. Medical management will consist of course, physiotherapy, exercise will help, and plus medicines which I just showed. Levodopa is the cornerstone. It is one of the best medicines which is available. It is a prodrug of dopamine. It will go inside the brain and then get converted into dopamine. So that is how it helps. All other treatments that are available to us, we all compare those treatments with levodopa. That is the gold standard. Levodopa is the gold standard. We compare all these treatments with levodopa. That is how good that drug is. But of course problems occur because then slowly patients start getting side effects. Initial 2-3 years, 4 years, are good. That is called the honeymoon period. So initial 4-5 years patient will get a very good benefit, but then after 5 years, 6 years, he'll start getting side effects. Then surgical management, we have pallidotomy, thallotomy, meaning we go into a particular area and we burn that particular area, or we take a lesion there, and that relieves the symptoms. And then we have advanced therapies like continuous drug delivery systems, means instead of taking this medicine through through mouth and stomach, and then it will go into the body, we give drug delivery directly, because then we can control the rate of the infusion, we can control how much drug is going, we can reduce it, increase it, and then adjust it according to the side effects or whatever benefits the patient is getting. So from that we have apomorphine. Another is, this is available in India, levodopa carbidopa intestinal gel. This is not yet available in India, but again this is a good option. Then deep brain stimulation, I'll come to that. And MR guided focused ultrasound is a newer therapy. Again, this has recently been available in India. It has its own positives and negatives. So deep brain stimulation. Deep brain stimulation is when what we actually do is we put two electrodes into the brain at in an area called subthalamic nucleus. Okay, it is involved in the pathway of movement. So we insert electrodes in that, and that is connected to a pacemaker here. Okay, which we keep in a chest, just like the pacemaker that we have for the heart. There is a pacemaker here, and through electrical impulses, it gives pulsatile impulses to this area, and that will relieve the symptoms. So I'll show one of these patients where we had operated him. Now before operating, we have to check whether how good he responds to levodopa. As a thumb rule, how much patient will respond to levodopa, that much only he'll respond to DBS. So DBS is not a foolproof therapy, but it helps improves the quality of life. So look at him, how much difficult it is for him to walk. Short steps, he's getting freezing, so his legs just freeze when he starts walking, and when he turns, so hardly few steps he has taken. Look at the time that he needs to take. It takes ages for him to just take 2 to 3 steps, and for that also he's requiring support. And balance is very precarious. He might fall if we don't support him. He might fall. Okay, so this is after giving him after half an hour or about 45 minutes of medicine. So with medicine, there is good improvement. Again, step length, stride length is improved, turning is improved, his arm swing has improved, he's moving his arms quite well, not normal, but okay, not bad. Now we operated this patient, we put the electrodes. Now this is the programmer, and we do programming. This is the first time we are starting the machine now, pacemaker now. So these are the contact points, 1 2 3 0 1 2 3. This is the left STN, subthalamic nucleus. So left controls the right side. So just observe. Now I'm first time after the operation, I'm starting the program, turning on the pacemaker. Now the current is very low right now, so just look at the tap, finger tap and opening and closing. Very slow, extremely slow. Look at this. Finger tapping, fist opening and closing is very slow. Now I'll increase the current. So I've gone up to 1, and almost immediately you will see the difference. Now look, the slowness has improved. Slowness has improved. Not fully, he still has a masked face, there are no expressions, but quite a bit of improvement. Now I'll increase it much further. So we have gone up to 1.5 volts. And you can see the area where that current is spreading, that also increases. Now again, it has increased even more. This the pacemaker is here and we have to connect it through a Bluetooth device. So again I have increased the current a bit more, and that again increases his speed. So now he has not taken medicine. He is off medicine for almost 24 hours, but we have turned his battery now, pacemaker now, and see the difference. He is able to walk much better. Arm swing has improved. Turning is better. So overall quality of life improves. Patient may not be full, he may not get 100% relief, but at least 50 to 70% relief he gets. So that is one option that we can give. That is one of the advanced therapies that we do. Then second is apomorphine infusion pump. So basically what it is just same medicine that we are giving through mouth. We can give, so apomorphine cannot go through mouth because it has a high first pass metabolism. That means the liver will destroy it before it reaches the blood. So we cannot take it through mouth. So we have to give it through parenteral route. So we give a subcutaneous infusion, and through a machine, small pump, it will keep on injecting the medicine slowly throughout the day. So the patient has to wear this device, and through a small subcutaneous infusion, there is a needle here, and patient himself can attach it, just like patients take with diabetes, they take insulin. Just like that, they can just continue with this throughout the day. He will keep getting the medicine. So this was one patient which we we have to give a first test dose to check whether patient gets a benefit from it. So this was the patient who had severe disability, and after giving the test dose, patient has quite a bit of improvement. So patient is able to walk without support. Again, this is not like patient एकदम 100% improve हो जाएगा, but quality of life improves, side effects can reduce. ठीक है. So this apomorphine infusion is helpful in patients who are not fit for surgery, or those who don't want to go for surgery, because DBS is a major surgery, lot of cost is involved, lot of things are involved. So patient may not be affordable, patient may not be fit, he may have heart disease, he may have severe diabetes, other problems, past stroke. So patient may not be able to undergo surgery, but then we can offer these other therapies which are which unfit patients can also undergo. And this is the third one. This is levodopa carbidopa intestinal gel, not yet available in India, might be available in the future. Right now available in Europe only. So here they actually the medicine, instead of giving through this is basically levodopa only, which we give through mouth, but here they put a device inside, and it keeps on pumping that gel into the intestine, and it gets absorbed. So again, this is helpful for reducing side effects which patients are getting. So to recap, look for rest tremors, means patient is not doing any activity and he's getting tremors. Usually they are unilateral, especially early in the disease, and later on they become bilateral. Mask like face, hardly any expressions. Reduced blinking of the eyes. Very slow, and this left side is much slower than the right. Fist opening and closing. Left side even slower. Right side is better. So alternate movements. Again, left side is much slower. So usually it is unilateral. Okay, thank you. So this was just an overview of what therapies are available and what work we are doing. Thank you. Questions? Any questions? Cost for surgery cost, there are different devices, but usually the minimum is around 15 to 16 lakhs. Maximum, if it's like a mobile, if you want the best one, then it will go around 23, 25 lakhs. If a basic device is non-rechargeable battery, if you want, it will go around 15 lakhs. Thank you.